And we are now recording, and I will turn it over to Russ Glasgow to start our introductions.
Thanks, Samantha, and good morning or afternoon, wherever you may be. Delighted to have you with us, and it's my privilege this morning to introduce my long-term friend and colleague, Dr. Jodi Holtrop, who will be leading our discussion today. Just very briefly, Jodi is the co-director and lead on our research consultations for our D&I group here at the University of Colorado. She's associate professor, soon to be full professor in the University of Colorado Department of Family Medicine in our med school here. Jodi has a long research background. She's worked with, I think, a number of you on the call here on health behavior change interventions, has more recently done a large amount of work on chronic illness management, and currently is working on several interesting things related to adaptations of interventions. And today she's going to share some of her expertise on qualitative and mixed methods approaches. So take it away, Jodi.
Great, thanks. So the title is really getting to the why, qualitative approaches with REAIM. So what's going to be discussed? Okay, why is this not advancing? All right, so first of all, acknowledgements and conflicts of interest. So I need to thank Borsica Rabin and Russ Glasgow and the University of Colorado program. Here is some of the funding that I have, so you are informed. I'm not going to be discussing anything off-label. And then Russ gave my background, so I'm going to skip over that so we have time for discussion. So this is what I was hoping to cover. Give a quick overview and history of REAIM, a quick overview of qualitative methods, and then blend those together, REAIM with qualitative methods. Talk a little bit about some issues in particular to qualitative methods with REAIM and some future directions and opportunities. And then hopefully we can save about 15 minutes for question and answer. So I'm assuming that a lot of you know what REAIM is, but for those of you who don't, here is just a quick overview. We are going to go through REAIM in depth as we talk about qualitative methods with use of REAIM. But if you don't know what it is, it stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. And these are the kinds of things that are studied with REAIM. Reach and effectiveness have to do with patient or intended audience outcomes, and adoption, implementation, and maintenance are more at the setting or intervention agent level. So we'll go through that more in a minute. So the purpose and history of REAIM is that it's intended to facilitate translation of research to practice. It looks at both internal and external validity, emphasizes representativeness, looks at both individual, like patient, and organizational factors. And the public health impact depends on all of the elements. So you're not just looking at what is the outcome, but what is the reach and how did you get there? A few summary points about REAIM is it's not a theory, but it does tell you where to look, where things often break down. It's an outcomes framework that can be used both for planning and evaluation, and we'll talk about that a little bit more. Each of the dimensions, so each of the letters, R, E, A, I, M, is an opportunity for intervention, and all the dimensions can be addressed within a given study, though likely not all intervened upon. And REAIM can be used for lots of different kinds of studies, observational, efficacy, effectiveness, and implementation types of studies. So REAIM has evolved over, gosh, well, Russ, you're on, a number of years. I'm thinking 15 and maybe is a number or more, and has been cited and used in over 430 published journal publications. So it's been utilized a lot. And one of the things that we noticed as we were looking at REAIM was that over time, the use of REAIM focused on quantitative outcomes, so numbers. In a recent review by Samantha Harden, who's our host today, 6 to 24% of studies using REAIM used qualitative methods across the dimensions. So that means like 75% or more in the past reported papers did not use qualitative aspects across, the REAIM dimensions. So the point that I hope I leave you with is that it would be really beneficial if you're going to use REAIM to do qualitative measures along with quantitative measures when you're using it. So very briefly, I know at least several of you here know a lot about qualitative research, but for those of you who don't, and I'm working to convince to be excited about qualitative research, it's a process of naturalistic inquiry that seeks in-depth understanding of social phenomena within their natural setting. It focuses on the why rather than the what, and relies on the direct experiences of human beings as meaning-making agents in their everyday lives. Qualitative researchers use multiple methods of inquiry, such as case study, ethnography, grounded theory, phenomenology. We'll talk about some different methods, but that's kind of a definition for us to start with. Or said in another way, if you look at this picture, quantitatively you have 5 marbles of 1.5 centimeters diameter each. But qualitatively, you have a bunch of beautiful rounded smooth glass marbles. Now beautiful is a bit judgmental, so we might not want to use that word, but at least you can see the difference describing something and its characteristics in a different way than just numbers. The beauty of qualitative is illustrated by this little comic here. So the first frame, it says, the little stick guy says, let's get a show of hands. Who here prefers quantitative data over qualitative data? He says, 1, 2, 3. Okay, looks like everybody. Tell me, why do you prefer quant? Well, quantitative data is the only way to really know, and then the lead stick figure interrupts. Oh, sorry, I should have mentioned, please use only numbers in your response. And the guy goes, 7? So what you get is a richness and a meaning and understanding from qualitative that it really, you just can't get the same thing from quantitative. Here's one of my favorite quotes: not everything that can be counted counts, and not everything that counts can be counted. However, people question its rigor. Here's another comic. Watson, I know what caused the death. And he says, but you have only administered a few interviews and going on 2 site visits. Should you not collect evidence that is more robust? So I just want to spend 30 seconds here saying what qualitative research is and some things about doing it well. Qualitative research can be very rigorous. It's just different. So what it's like is the column over here on the left, open inquiry. So you're asking open, curious, inquiring questions. So tell me about that, all right? It's inductive. You have open mind towards what's happening. Naturalistic, it evolves. It's descriptive and interpretive. It allows you to look at things from multiple perspectives. It allows you to be cyclic, so you can repeat back through it in cycles. It allows you to attend to the context as well as focus on the particular. But there are some things about doing it well that I just want to mention, and then the next slide has a reference to, I really do want to do qualitative and I want to do it well. But some things to keep in mind are clear study questions and methods, being transparent, so sharing what you're doing, why, your own biases, what your perspective is coming into it, what you did, how you did it, which helps lead to unbiased data collection and analysis. So you probably can't be totally unbiased because you're a human being and have your own belief systems, but yet you try for that. You use a skilled and multidisciplinary team. You triangulate, which means if you're looking into a room, you're looking at it going in different doors so you can see all parts of the elephant, not just one method. So you're trying to use all of your data to look at it from different angles. Many passes through the data, so you're running through it again and again and again to really understand what you have there. Many data sets. Immersion in the topic, in the literature, and the experience that you're having, and knowing your data and representing it honestly. So if you follow, this is the Consolidated Criteria for Reporting Qualitative Research, or COREC. It's a 32-item checklist. That always makes me chuckle, qualitative, you got a checklist of things you have to check off. So anyway, but these are some things to look for if you want to do qualitative research, you want to do it well, and you want to report it well. You might want to look at something like this. All right, so in terms of qualitative data collection methods, let's contrast that with quantitative methods. So quantitative methods are things like tests, surveys, codings, not qualitative coding, scoring, biometrics, lab data, you know, a lot of numbers. Qualitative methods collect interpretations and understandings. So you interview people, you observe them, you do focus groups, you do field studies. So let's dive into that a little bit more. So I'm going to give kind of a quick, very, very quick overview of some qualitative methods. This is not comprehensive, but it gives you an idea, and hopefully you can think about different ways to do this. So one of the ways that you can collect qualitative data is ask people questions. So you can do that in a group, or you can do it one-on-one. You can do it online. There's probably other ways, but these are kind of the main ones that I'm thinking about. And I just want to make a point here. So a lot of people come to me for qualitative consultation, and they want to use qualitative data collection. They'll say, so I'm going to do a focus group. Well, there's nothing wrong with focus groups. Focus groups can be efficient. So essentially what you're doing is you're getting people together in a group, and you're asking questions of people in the group. All right, so that gets lots of people together at one time. So yes, that can be very useful for certain kinds of things. So say, for example, you want to kind of get a group think about something. You want to develop a intervention. You want to know how people feed ideas off of each other. A focus group would be a great thing. However, if, for example, you need to explore in your research the sexual practices of people, or some sensitive topic, or how people get along in a practice and they don't get along very well, that could be really not good. It wouldn't be a good setting because people really wouldn't want to disclose those kinds of things in a group. It is more efficient. So, in terms of, gathering data with less time for you or your research assistant, but it has its benefits and drawbacks. So my point here is that a focus group is one method, when selected thoughtfully, can be great, but there is a lot more that you can do. I personally am a big fan of one-on-one interviews. So I'm going to talk a little bit more about different interview methods. So on the top, there are 4 bullet points, and it goes from oral survey to unstructured interview. This is just to make the point that there are a variety of ways to do interviews. An oral survey would be simply asking people questions, and they could actually give a number answer. So that would be like a survey. It just means that you're asking the questions out loud instead of having people read them. So that would be very structured, all the way to something very unstructured, which is very open-ended questions. The bottom 3 points are some different interview methods coming from some different perspectives. I just mentioned 3 that I like. There are a lot of other methods, but the reason I mention them is a lot of people will say to me, oh, well, you just do an interview and you ask people about their, what they think, like why it worked and why it didn't, and that's it. Well, there's a lot more that you can do with an interview. One example is a critical incident analysis. So this takes a specific incident and delves into what happened with that incident. And it allows you to get a little bit deeper into people's thinking at the time and see the kind of interaction of their thinking, feeling with something happening in context. We use this for a study looking at smoking cessation with young adults using a text messaging program, and we inquired about how they used the text messaging program when they had an urge to smoke, for example, and really kind of delved into that, and it helped us learn a lot more about how this intervention was helping or not helping these participants. Task analysis or cognitive task analysis or even process mapping are ways of seeing workflows and seeing how tasks get passed from one person to another and happen over time. It helps illuminate steps or procedures, who does what, and when processes break down. And there are some specific techniques and methods to get at that, but that could be very useful, and it's still an interview. Appreciative inquiry starts from the standpoint of what works. We used appreciative inquiry in a recent study looking at patients who have chronic pain. And they were describing themselves as successfully managing their lives with chronic pain. And pretty much our whole interview guide, it was very unstructured, was, so tell me the story how you are successfully managing your pain. And they told us their story. And then we asked probes for, kind of follow up to learn more about specific details. But it was really like trying to figure out what works in a situation. So those are some examples of different methods of interview techniques to get at different types of aspects. All right, so another thing that you can do is watch people. So I think this is really, really underused in implementation research. It maybe takes a little bit of courage to do. So along this continuum, there is one thing to think about, which is, are you a participant observer or are you just a complete observer? So a participant observer is someone kind of like, living among the natives. Maybe if you're a physician, you actually do some physician work in a practice or a healthcare setting along with people as you're learning and observing and watching what's happening. To over on the other end is a complete observer, who is someone you may be sitting in a waiting room just watching patients, not talking to anyone. So that's one dimension to consider. The other is, kind of in the middle, where you're shadowing and observing people, maybe asking a few questions here and there. I have found observation to be one of the most useful aspects of studying new interventions as they are adopted and implemented in practice. I've done a fair amount of work in the area of looking at care managers as new roles in practice for chronic disease management. And we've spent time just, following care managers as they're doing their job, spending a day or two with them. And it's really interesting when you interview them and they say something like, oh yes, I'm just so busy with patients. I talk to patients all day and, I spend lots of time with them. And then you go and observe and spend 2 days with them and there's like 2 visits with 5 minutes on the phone. So that gives you, a much, much richer picture of what's actually happening. And you can see how they interact with other people and what they're actually doing. And it's not just whatever picture they want to paint for you because they want to impress you. So it really helps with triangulation of data. So I just want to say this. Here's Calvin and Hobbes. And if you're a Calvin and Hobbes fan, I just want to say it's not creepy. So here's Hobbes. Why are you following me around? And he says, Calvin says, why are you following me around? Why are you repeating what I say? And why am you repeating what I say? And if you're going to keep doing that, I just won't say anything. And then he repeats. And he says, the incredibly annoying human echo strikes again. If you are clear about what you're doing, why you're there, there's consent documents that you can use when you observe patient visits. You can consent the patients and just say, hey, I'm just trying to learn about this role, and be very respectful. It's not creepy. It's really, people are actually flattered most of the time that someone is so interested in what they want to do. They want to spend time with them and really learn from them and say, you have a real opportunity to add to our knowledge of this new role or what you're doing. So other methods, very briefly, these are really not used very commonly in dissemination and implementation research. Photo voice, digital storytelling, and document reviews and artifacts can also round out your understanding of what's happening as a study unfolds. Photo voice is asking people to take pictures. It works really, really well for elements like trauma or there's emotion. So having people take pictures of what does stress and burnout in the workplace mean to you. Have people take pictures of that and then come back and tell you about that, either as an individual interview or as a group. Digital storytelling is a variation of that with really more video. And I also want to emphasize document review and artifacts is really helpful information. In our research looking at care managers, what we found was, like taking screenshots of the care management software they were using, getting meeting minutes, looking at their educational materials, things like that are documents or artifacts, taking pictures of, the workplace settings so you can kind of understand the constraints are really, really helpful in really getting at what's going on here, and why is that happening. So now I'm going to go back to REAIM and jump to that again. So if you use REAIM, you can use it in a couple of ways. Now you'll notice that you've got the reach, effectiveness, adoption, so on over here on the left, and then key planning questions to consider and answer. And so each question is phrased as a kind of future tense and a past tense. So you can think about the questions that you're asking and how you might answer these things. using quantitative and qualitative methods. So the first one, reach. Who is intended to benefit and who actually participates or is exposed to the intervention? As it's a planning question. As an evaluation question, then you can say who was intended to benefit and who actually did participate or was exposed to the intervention. So you can use this in both ways. And it's great as a planning framework so you can think about what, who you're really targeting, why, etc. And also as the researcher, you can plan out how you're going to organize your data collection so that you can get at this quantitative and qualitative aspect. All right, so what I want to do now is go through an example with just a very typical kind of thing, a diabetes self-management program. So let's say, hypothetically, that the intervention is this diabetes self-management program, and it's available to patients within a health system. The health system has 5 practices, and the implementation strategies are that there's a setup referral approach where the program, so the people leading this diabetes self-management program, go through and they find patients that might be eligible, and then they send messages to the primary care providers and ask them to refer to this program. The providers get training on how to introduce the program and make the referral, and then the program gives the results back to the providers regarding which patients participate, how they're doing in the program, and the providers are prompted to share information on progress with the patients. All right, so let's take this dimension by dimension. Okay, so let's start with reach. So quantitatively, we might want to know how well this program actually reached the patients that we were interested in. So let's say out of 200 eligible patients, 100 people actually participated. All right, so they actually came to the program. Of those people that participated, so another aspect of reach is what are the people like who participated? So you probably have some quantitative information demographically, the frequency of patients with certain characteristics. So maybe what we found is that 90% of those participating are white, female, privately insured patients. However, our patients also include male, other races, and Medicaid. So we might get that information by looking at participation records and patient characteristics from the medical record. So we know who participated and how many, but what do we not know? Well, why was it that only 50% participated? What happened to those other patients? And why did patients with only certain characteristics participate? What other characteristics about the patients besides just their demographics might be driving this participation or lack of participation? So some ideas qualitatively is that you could listen to the non-participants and ask them. Now you don't want to just go, hey, why didn't you participate? But you can say, hey, this program was offered. Please tell me about, what kinds of things made it difficult for you to participate, or what kinds of things were you thinking as this was offered to you? And you can learn a lot more about who did not participate. Maybe you could use photo voice and have the participants take pictures of what their diabetes means to them in their life. And you would learn a lot more about who is or is not participating and what was driving that. In terms of effectiveness, this is also a patient or intended target person measure. So quantitatively, okay, so the goal of a diabetes self-management program is likely to try to reduce A1C. That's what all diabetes management programs seem like they're trying to do. So you can see that there was the goal of the program is to get patients to have their hemoglobin A1C less than 8. So 50% of the 100 participants were able to do that. I'm being very positive. That's probably not happening. But the mean reduction overall was 0.7%. So, we can get lab values and look at the medical record for that. But what we don't know is, well, is a 0.7% reduction or having 50% of the patients reduce their A1C clinically meaningful for anyone? Like, what does that mean to the patients? Is that worthwhile for them? Is this enough of an improvement that the providers are going to be interested in this? Is A1C even an appropriate indicator of diabetes control? Whether their measures are meaningful that impact patients' lives? What are the characteristics of the patients that did not improve? So some qualitative, methods that we could use is, again, a method of interview, but maybe we want to do a critical incident interview with patients. Maybe we want to observe practice teams and listen, maybe they have some meetings where they discuss the implications of this, and you want to sit in and listen to those meetings so you can hear the providers discuss amongst themselves whether this is, a good change or not a good change, or, what it means to them. So now we get to the intervention agent and setting level dimensions of REAIM. So quantitatively, we want to know both at the setting level and the provider level. If the providers are the ones making the referral, we learn that there are 5 practices, and the intervention, meaning the diabetes self-management referral, happened in practices A, B, and C, but not D and E. And in practice A, providers 1, 2, and 3 referred patients, so the physicians referred patients, but not providers 4 and 5, the physician assistants. So we might learn this information by tracking participation, and we could even maybe do a survey, like a written survey with a Likert scale items, like, so you could learn something about the adoption that way. But qualitatively, you can see the theme of the why I titled my talk the why. Why did some participants or some practices refer patients and others did not? And why did some providers refer patients and some did not? So maybe what we might learn by looking through, document review from meeting notes, interviewing with non-adopters, and maybe using a WISE exercise and practice observation or shadowing of roles is that, we might learn some things about this. Maybe the physician's assistants get less time with patients than the physicians, so they don't have time to make the referral. Or maybe they believe that their role is one such that, this isn't something that I'm supposed to do, only the doctor does that, and, I'm just kind of handling acute issues. So it really gives you a lot more insight into how this can be adopted widely rather than just, with certain types. Implementation. So this is a big bucket category with a lot in it. Lots of things related to implementation. So how did it go? How did this referral work? So quantitatively, you can look at percent adherence to the core components. So, did they do certain components of this as they were supposed to? The cost to implement, the dropout of implementation, the types of unintended consequences. So these are some things quantitatively. Maybe we could have the staff complete logs with checklists of things they did. I did this, I did this. That's probably going to get pretty onerous, though, for them, and they might revolt and not do that. You can look at costs, so you can look at reimbursement, maybe for the program. You can look at, other outcomes, in terms of unintended consequences. Maybe the patient's diabetes, measures went up, but then they get worse on something else, like their blood pressure, I don't know, some other aspect that was not intended. But lots and lots of qualitative questions here. So what was the impact of the program delivery costs? If it takes the healthcare providers, an extra 5 minutes, and then they get behind in schedule, and, and then they have less patient visits, that could have a cost to the practice. Did the participants find the intervention acceptable? Did they find that this was just kind of a pain and they stopped doing it because it just, the system didn't work very well for them? Were there certain parts of it that, didn't work well for them? Maybe they were referring, but then they don't read the notes that come back and they don't discuss things with patients. Were they able to implement the core components with fidelity? What made it difficult or not possible to do so? What adaptations occurred, and were they planned or responsive? So did they intentionally, change something in the process, or was it because they had to in response to something not going well? And again, what were the unintended consequences? So again, lots of ideas. You can see the theme here of interviews and observations, but there's lots of different kinds of ways that you can gather this data. So, watching patient visits and seeing how does the medical provider introduce the referral. When we were shadowing care managers, I had one physician who said to the patient, yeah, I'm going to, he was supposed to be referring to the care manager. He says, I'm going to assign you a NAG. I thought, well, that's really interesting. I didn't think that a care manager was going to be a NAG. So you learn a lot by watching what's happening. You can look at, you know, a process mapping with cognitive task analysis or maps, where you can learn, you know, how the workflow might influence their ability to do this referral. You know, they're you know, trying to do a million different things, and there's all these interruptions, and then they forget, and, you know, etc. So maintenance, which is, you know, the sustainability of the intervention past, you know, your study. You can track site participation. I'm going to run through this one pretty quickly because I think you get the idea. But what factors were in play that caused some practices to stop referring? My favorite is, oh, well, the study was over, so we didn't have to do that anymore. So, you know, if it's something that is really implementing well and people really see the value of it, they're going to tell you about it, and you're going to see that happening in your observations. And then you can also, you know, see where that becomes something that is routine and that they want to keep doing. All right, so that was our quick example. But the point is here, for each REAIM component or dimension, you can see how there are quantitative data collection and qualitative data collection, and that the quantitative can tell you, I'm at the bottom, the key questions, what happened? But the qualitative can tell you, why did it happen and what influenced its happening? So I would like to posit that understanding why is really, really critical. You know, why is it critical? Well, sometimes you don't know why you didn't get an intervention effect. Qualitative will probably tell you that. All right, so characteristics of qualitative research give you perspective. Over here on the right is a little, you know, figure here, and the person on the left says, my, that woman is so tall. And the other person says, no, she is so short. Maybe the woman is 5'6", and that's your quantitative measure, but your perspective is variant based on who you are. So some things that qualitative research seeks to do is to seek the truth. Was it the intervention or the implementation that, you know, maybe if you didn't get good results, what part of it was, you know? The importance of the context. How did the setting contribute to adoption or not? Maybe, you know, with this diabetic intervention, you know, like some policy gets changed that, you know, Medicare now pays for diabetic, you know, education or diabetic self-management or the diabetes prevention program, and therefore the patients don't have to pay for the program. So, you know, that gets them more excited to participate because it doesn't have a cost. The importance of meaning. Did this add value to the patients' lives? Did this add value to the people who are doing the referrals? Did it help them make, you know, them feel more in alignment with what they're trying to achieve? The qualitative researcher as an instrument, and this is the importance of the perspective, is to remember that different people come at this from different perspectives, and you do too. So try to be informed, understand the, you know, context and circumstances and literature, but also have open eyes and consider those multiple perspectives. And that the more you can immerse yourself in understanding a situation, then the more you're really going to have a fuller, richer picture of what's truly going on to inform the science of whatever you're trying to work on. Okay. All right. So a very, very quick discussion of analysis methods. We just don't have time to do, you know, this service, but I would like to say, even though it might feel like qualitative is this guy over here on the right where you're jumping off a cliff and you know, your wheels are falling off, it really isn't like that, because there are lots of methods to hold you. I'll start with kind of the most basic, which is you have all this text from all these interviews and observations and notes that you've taken. What do you do with it? So thematic analysis is one of the basic things that you can do, and really you're trying to identify themes across data. Very commonly in D&I research, people do, you know, interviews, and then they say, what about this worked? What about this didn't work? So this is the typical barriers and facilitators. There's nothing wrong with that. But it is a little bit surface-ish, you know, and then you just kind of say, well, the main reasons that, you know, people didn't use this is it cost too much and it didn't work with their lives. You know, that's kind of more like a thematic analysis. A matrix takes it one step further, and it looks at the pattern of meaning across units. I love matrices because what you can do is say, what were the themes? So if you imagine a table, the themes are maybe the columns, And then how do those themes represent across your units? So the units might be primary care practices. That's where I do a lot of my research, or schools, or churches, or whatever. And so you can look at the cells. So how did, this aspect of cost vary across the different practices? Was it important for some and not for others? Case studies is in-depth understanding of a case or several cases. The idea, maybe you've heard of positive deviance. You pick out some cases that are really successful. Boy, they implement, chronic pain management really well. How are they doing that? And you go and you do this really comprehensive assessment and study of, what those successful cases look like. Grounded theory is very, very popular, and I think sometimes people don't use it appropriately, but what it really, really means is you immerse yourself in your data, you learn from it, and your, theory, or how something's working, why something's working, emerges from your data. You're not coming at it with, a sense of like, this is what's happening already. You might have an idea, but you're letting your data guide you. So it's kind of from the ground up. Phenomenology is understanding a lived experience or phenomena. So that's another approach you can use. Ethnography is very popular, come from anthropology, so the importance of context and culture. And then immersion crystallization is really immersing yourself and doing your data analysis in a different way so that you're really passing through it many, many times and from many perspectives to understand the meaning and the key, aspects of meaning. So I'm just going to very quickly mention that there is a paper that Russ Borsica and I wrote that kind of encapsulates what I'm talking about today. And in that paper, we do work through an example showing, some of the things that I've talked about already. I'd like to point, though, to a couple of the complex issues that we point out in that paper and why qualitative is really important. One of the things that you'll get from qualitative is really understanding the pattern of results across RE-AIM dimensions. It's pretty common to have, do well on maybe one of the dimensions and not as well on another. So what if you get a high reach but low effectiveness? What does that mean? Or low adoption and low fidelity, what does that mean? The qualitative aspect of the work will help to fill that in and help you to understand those results. We recommend using frameworks and models. If you know anything about D&I, you know that we love our models, frameworks, and theories. And those aspects can really hold your qualitative inquiries. So you can use the analysis methods that I mentioned in the previous slides to kind of hold you. But when there are models and frameworks that might guide you, then you can use those as well. For example, a very popular and predominant framework is the Consolidated Framework for Implementation Research, or CFIR. It has 5 buckets of implementation issues. So if you're trying to look at, what's happening with this referral program to this diabetic education program or self-management program, I can know that if I use CFIR, I might want to look at, look to the inner setting, or, the practice in the hospital or health system. I might want to look to the outer setting, the context in the community, or the, the perspective of, the payers. I might want to look at the participants themselves. I might want to look at the intervention itself, and I also might want to look at the process. So those are the kind of 5 buckets that you can use to kind of guide your inquiry so that you're not just kind of feeling like you're floating around not knowing what to ask. Another aspect of RE-AIM use with qualitative is delving truly into mixed methods. So how does the qualitative and quantitative results inform each other? I did not get into that today. I'm going to mention one thing very quickly that I'd like you to think about in the last 5 minutes of my talking. It's just a little teaser on a mixed method that I use that I really like, and I think it's really useful for implementation research. So I'm going to have some slides on that. And then this aspect of qualitative being rapid and iterative user-centered design approaches. So I'm going to talk a little bit about those 2 things. So you're probably seeing a little bit more coming out about rapid assessment approaches, or RAP. Qualitative research is known sometimes for taking a long time. And so you go through and you collect this data, and then you put it into a qualitative software program like Atlas TI, and you analyze it, and you use your team, and you do all those things that I just mentioned to do it well. But that takes a long time and a lot of people and a lot of resources. So there's been this question of, should we do this faster? And why you might want to do it faster is to inform the process as it goes. Maybe you need a product out of it. Maybe you want to inform the next stage. Maybe you're on a timeline. Maybe you need to strike when the iron is hot. And I stole a little bit of this from Allison Hamilton's presentation. So thank you, Allison. But is that it is an intensive team-based qualitative inquiry using triangulation, iterative data analysis, and additional data collection to quickly develop a preliminary understanding of a situation from an insider's perspective. So she makes the point too that rapid is not rushed and that it's not of poor quality. It just means that you're doing things more iteratively. One of the things that she talks about is this sort and sift, think and shift aspect. So really that you're collecting data over time, and I'd like to bring in the time element to this data collection that I haven't talked about yet, which is usually when you do qualitative data collection, you're doing it over time. You may come in and you do baseline data collection, maybe during, or maybe not, and then after is a typical pattern for data collection. So at each of those time points, you can collect some information, summarize it at that baseline time period, learn from it, and then, it could be part of the intervention. This is very user-centered design-ish feeling to me, where you collect some information and then it informs the next step of what you're going to do in developing something. So whether you're developing something or not, you can use this diving in, stepping back, diving in, stepping back. A recent paper Russ just shared with me this morning looked at, and I don't remember the exact outcomes, but what they did was they compared rapid methods to a grounded theory method and looked at to what extent you got the same information and it was of the same quality and amount, and there was some overlap, but there was also some gaps. So I think we have an opportunity to do more work in this area. Okay, so this is my teaser about a method of mixed methods. So there's a lot of ways you can mix methods, but it's truly mixed methods if you take quantitative and qualitative information and they inform each other in some way, or they are merged together in some way. The reason why I'm mentioning QCA is it is inherently a qualitative method. So you take qualitative data and then you turn it into numbers. So this is a mixed method technique where you're converting qualitative data into quantitative data. And I'm not going to tell you how to do it because that would take like many hours, even just to kind of explain it, but I'm just going to kind of try to tease you a little bit about what are some of the main concepts and why you might want to use it in a D&I type of study. So really it does involve math. So my little table here shows you if you are statistically inclined and you like numbers and you like to do statistical analysis, this math is not statistics. It is applicable to non-normal, non-linear data, and it allows for small sample sizes. So a couple things about it is it helps to identify conditions that produce or are related to an outcome, either singly or in combination. So for example, we were trying to understand registry implementation in primary care practices. What we found was there were some necessary ingredients. So necessary ingredients are those that must be present to produce a good outcome, but don't guarantee a good outcome. So some of the necessary ingredients were things like good leadership and a quality improvement mindset. You want it to be forward thinking to be able to actually think about implementing a registry. But sufficient conditions are those alone in a combination in different contexts that can produce a good outcome. So for example, what we found was that in small practices, they needed certain conditions to get the registry to happen. They needed a a medical assistant that was, or some other person in practice that was willing to go forth and learn how to modify their electronic medical record. In large health systems, you had to appeal to the, quote, some people said epic gods, to get them to build a query path so that the EMR could be set up as a registry. So the point here is that it gives you combinations of conditions that relate to an outcome. And this can be very, very useful for implementation studies, because you can pick out, well, what needs to be there and what sometimes needs to be there. And this is just a couple of my really basic drawings, is that it relies on the principle of looking at coverage, how relevant. So you can see this little dot here on the left. It's inside the circle of the outcome, registry implementation, but it doesn't cover very much of the territory, right? So, maybe that variable condition theme is important, but it's not very important because it doesn't really explain very much. And then the principle of consistency, so how related. So you can see that these circles overlap, but there's a lot of other things going on. So maybe a particular condition related to an outcome. So in our example with the registry implementation, say, certain people, are important, but there's a lot of other factors. So I just leave you with those principles, probably very confused, but I encourage you, if this sounds interesting, to go look and learn more. So in the end, what we're trying to do with pragmatic or DNI research is create research that is relevant, rapid, and recursive so it can be useful quickly, is rigorous, reports on what resources are required, and replicable. So I would challenge you to think about, how does this relate to what we collect qualitatively? And that qualitative will help us understand this much better. I'm almost out of time, so I'm just going to go through this last couple of slides very quickly. So there is a report that I'm going to show you in the next slide. The first item on the resources list is the group is called Qualris, and they created a report about needs for qualitative research and implementation science, and these are their points. So if you're interested in what to do next, here's some ideas. So here's some resources. The first one is that report that I talked about. So these slides will be available later. I just like to draw your attention to the DNI program. Here's our website at the University of Colorado, and we have a lot of resources on the website, and these are the things that we do. So I am finished.
Well, thanks so much, Jodi. That was phenomenal. Can people hear me okay?
I can.
Okay. Well, super. You covered so much and so well. That's great. I'm sure we could talk for hours, but we only have a few minutes left. So I wanted to make one comment and then start the discussion from a question we had on chat. The comment is just that I think Jodi has summarized things nicely, but there's been an explosion, I think, of interest belatedly on qualitative and mixed methods in DNI more generally. And this Qualris group, which is an NIH, across NIH group that was started and facilitated by National Cancer Institute. So it has some thought behind it, and it consists of a group of real national, a little bit maybe even international leaders. Borsica is one of the members, but I encourage you to keep track of that too. My comment is just that I think we're in REAIM increasingly interested in contextual factors and things that that drive our REAIM outcomes. And from my estimation, qualitative, at least today, are the best way to do that. So with that comment, let me turn to the first question we have here, and please type them in your chat box. And that is, how would you disseminate your qualitative findings that you have to non-research audiences? I don't know if you could have an example of that, Jodi, but given the complexity and things like that, just do you have any tips if people want to share your qualitative findings with more of a community type audience?
Yeah, I mean, I think that REAIM is naturally very conducive because it's just very practical and makes sense to people. And then the question, you know, the slide that I showed with the questions, which is like, who are you intending to reach? You know, you don't have to be a researcher to, you know, to be able to think about that. It's like, well, who am I trying to influence? You know, who do I want to, you know, have benefit and in what ways? So I think that the question slide, that planning slide is really, really helpful. In terms of the results that you get, you know, examples and then breaking it down into, you know, kind of what those main themes are is really important and helpful. So that, you know, I actually think that qualitative results are a lot easier to explain to people because they're not, you know, statistics and numbers, but they're really kind of stories and meaning. And so, you know, a lot of times people will say, you know, well, what kind of research do you do? And I've done this care management research, and sometimes framing it in what's missing helps. For example, people say, well, like, what do you study? I say, well, I'll study healthcare delivery. Well, I've been studying care managers. Well, tell me about that. And I said, well, you know, when you go to the doctor and you get diagnosed with diabetes or, you know, high blood pressure, and they send you to this nice lady who's a, you know, nurse or social worker, and she explains all of that to you, and she calls you and helps you to figure out how to do that. And the person will say, well, I don't have that. And I say, exactly. That's the divide that we're trying to cross. So, you know, it's making it real in people's own circumstances really helps, I think, convey the message. I hope I'm getting to the essence of your question.
Super. Thanks, Jodi. And again, we'd like to take as many questions as we can, so please try to be concise. We're monitoring it. And Jodi, if you have a way, you might want to look at the chat box too. I'm picking out one or two, but you might have one that you'd rather answer or you think is more directly related. But the question I'm seeing here is, do you have a recommendation in terms of mixed methods? When, to paraphrase this, if you have to make a forced choice between quantitative or qualitative methods, when would one be better suited to evaluating one of the re-aim dimensions?
Okay, so I'm pulling these up. Okay, Julie, thanks for the hard question. So Julie and I just presented last February, I guess it wasn't just, a mixed methods presentation on how to you know, integrate qualitative and quantitative methods. When it comes to re-aim though, you know, I think it just depends on what you really want to know. I mean, if you know, along the dimension, there are these implementation, effectiveness, implementation hybrid designs, which is a continuum of how much you're focusing on effectiveness and how much you're focusing on implementation. So, you know, on the, you know, kind of type 1 side, if your study is more really looking primarily at, you know, does this intervention work effectively, you'd really probably want to know much more quantitatively about the outcomes. Like, does this work? You know, does the diabetes education program or, you know, self-management program actually help patients manage their diabetes better? And what does that look like clinically? So you'd want to focus more there, maybe on, you know, that kind of study. If this, if it's more on, like, you know, on the implementation side, and you're just kind of studying patient effects, you know, you want to look at that, but you really want to put a lot of your effort into the bucket of deeply understanding, how did this roll out? What about it worked? What about it didn't? What, you know, where are the drop-offs and how this happened? So if you're, you know, gearing up for wide dissemination, you really want to put much more of your, you know, eggs in the bucket of, you know, really understanding the why. So, you know, I think the what and the why are both important, but you have to make resource choices. So I don't know if I'm getting to your answer, Julie, but I hope so. But we can talk about it later more.
Thanks much, Jodi. One quick request, and then I'm going to turn it to you and Samantha, because I've got a unconscionable amount of background noise here. But okay. Jodi, if you could, while we're finishing up, return to the resources slide you had. That might be great. I'm sure Samantha is going to post the talk on the re-aim website, but people might want to get real-time some of those resources. And with that, either you can pick one or Samantha can moderate from here on. And great, thank you so much. This has been wonderful.
Thank you. So here's the resources slide. If I'm going to look and see if there's any more questions.
There's just one more, and it's, when is the REAIM framework most applicable as compared to other approaches? So maybe some guidance specifically in the qualitative realm as you've been deciding, and maybe in a little bit more detail, even though we're almost at the top of the hour. As you've already mentioned, it's really pragmatic and it's easy to translate to different target audiences, but maybe why you chose to use the REAIM framework as one of your implementation frameworks.
So I will self-admit with transparency, a big fan of REAIM. And also there is another model that includes REAIM that Russ and others have developed called PRISM, Practical, Robust Implementation and Sustainability Model. PRISM, that includes REAIM and kind of drivers of how you get to REAIM. I really almost always use REAIM as kind of the outcomes and increasingly planning framework, and then use other frameworks, models, theories in combination. So for example, maybe you might use REAIM for looking at the different outcomes, and then you use CFIR, I mentioned CFIR, so I'll use that one to kind of drive your inquiry around, you know, what are the specific implementation aspects more thoroughly. So I'm a big fan of using the combination of REAIM with other types of aspects. I think it would be really hard to do a true D&I study without looking at those outcomes. So you might want to, you could use, I guess, a little different language and pick out different components, say within implementation, but I think it's just like the framework to hold what you're doing. And the message I have is just related to the qualitative. It just helps you to understand why you got what you got, So, you might know what the result is, but you don't know why or how you got there. So I don't see any more questions in the chat box, so I was just going to mention in terms of these resources, this NCI report, Qualitative Methods in Implementation Science, that's on the top. If you put that into your, your little Google search box, it will pull up a website. And the website, when I was copying it, was very long and cumbersome, so you will be able to find it. And this is that Qualris report that I mentioned, and it has the recommendations that are on the slide previous to this in terms of, and it is a really nice summary of not just REAIM, but qualitative methods for implementation science in general. There's a couple of mixed methods references here, and as well, the last two are references towards qualitative textbooks that describe different methods. The Crabtree and Miller one is one that I've used a lot. I really like how it's organized. They are going to be coming out with a 3rd edition soon, so I'm excited for that. And then there's a Silverman book there, but if you really want to use qualitative methods, there's some good resources on how to do that out there.
This is a great list of resources, as was the presentation, both in terms of the overview of REAIM, of qualitative methods, and the robustness, as well as combining the two. So thank you so much for your time and your presentation, Jodi, and thank you everyone else who was able to listen live. But as has been mentioned, this will be posted on our re-aim.org website. So we hope to see you at our next webinar. Please feel free to contact me with any suggestions or sharing any of your work through this mechanism. Thank you so much. Have a great afternoon.
Thank you.